Today we are talking about opportunistic pathogens.
Ooh, spooky, spooky.
Amy,
Halloween
I
came
know it's
early
like
this year.
almost, yeah. We're at the midpoint between Halloweens. I feel like it's appropriate at this point, but let's get right into it if we may. So we have a few things on our agenda for today, but let's start out with when we were off air before we even started. You had a really solid point about naming these things opportunistic pathogens, and maybe we should rephrase it just a teeny bit. And can you paint a picture between opportunistic pathogens that we're going to discuss today versus an outright pathogen? Let's start there.
Yeah, as we were talking about prior to jumping on, pathogens are microorganisms that you really don't want in your body in any amount. So even small amounts can be really problematic, and they're not necessarily a normal part of the ecosystem. Opportunistic pathogens, or again, as Nikki helped me configure, might be a better way to describe them could be just opportunists. I think when you start labeling them as a pathogen, even if you preface it with opportunistic pathogen, the second you add that end label of pathogen, everyone's going to be a bit spooked and going to think, whoa, I better get this pathogen out of my body. And then we kind of ignore the opportunistic part.
Yeah, well, I'll give an analogy to this. What if I told you had opportunistic cancer?
Right.
Holy crap, you would still go into 10 out of 10 panic mode, would you not? So I really love this point that you made off camera, that labeling these things as pathogens is probably a slippery slope, and it's probably going to feed into or cause or exacerbate a lot of health anxiety and this mentality of, oh my God, we have to obliterate these things, versus the reality, even for things like the dreaded Candida, or even something like C. diff, or certainly something like Klebsiella or E. coli. The reality is that you're going to have a little bit of these guys in you probably all the time. And the goal is not to be 100% free of Candida. The goal is not to be 100% free of Klebsiella or whatever it might be. But because these are opportunists, they only give you trouble when they have the opportunity to do so. So really, more of our focus with this group of bacteria and yeast and critters needs to be on what is giving them the opportunity? What is opening the door for them to give you heck? And then that needs to be where our treatment is focused. But before we even get into that, could you maybe rattle off a handful of quote unquote opportunistic pathogens, or opportunists as we are choosing to label them?
Yeah. And I know we were talking about how a lot of the popular stool tests have opportunistic pathogen pages. So sometimes those are the ones that kind of come to mind. I think Klebsiella, Pseudomonas, sometimes you'll see Morganella, some of these things popping up on the opportunistic page of some of those tests.
Yeah.
Sometimes I'll see desulfibrio type stuff, like sulfur producers being thrown in there. Sometimes the methane producers get thrown in there. But strep. Yeah. I think, again, it's so interesting because I viscerally remember when I had stool testing done, my practitioner, she was doing more of the Genova GIFX stool testing back in the day. But I remember getting that run, and a Proteus bug came up, and I can't even remember what the species was, but it was this Proteus one, and it was labeled opportunistic. And it was really the only major one that came up, if I remember right, in terms of a boogeyman or bad guy on this test. And I remember being maybe we need to go in with an antibiotic. And she considered it. And the wild thing is, I see this often in practice too, is where providers are actually going in with antibiotics for opportunistic bugs, which I think is a horrible look and a horrible strategy to go in all guns a-blazing for some of these microbes. I don't know, with the big guns out the gate.
Not only is it unnecessary, right?
Yeah.
Again, if you had Campylobacter or something, one of the big players, or if you have a worm, great. Go for the prescription stuff. I would not judge you a bit. But to go in guns a-blazing with prescription antibiotics for something that you find on page 3 of the GI map, for example, is just ludicrous. And the irony and the frustration from our standpoint is when we see this happen, oftentimes from quote unquote integrative MDs or like IFM trained MDs and DOs, right? Who are supposed to be more holistic, but not tremendously. They'll go in and say like, oh, I'm treating the dysbiosis with this antibiotic, but they're not putting 2 and 2 together that the thing that causes dysbiosis is antibiotics.
Right. Right.
So you're actually making the problem 10 times worse every time you try to treat this problem. I'm using air quotes, by the way, if you're just listening audio only.
Yeah, I know. It's mind-numbing. And it's weird because we might have talked about this in previous episodes. I'm sure we have. But how those providers will be like, antibiotics are bad and like overuse is what's created dysbiosis, but then they're overusing and abusing them in practice. And it's just so mind-numbing. And even I think there's a progression typically with something like an opportunistic bug. And again, there may be a time and a place for like a little bit of an herbal potentially, or like a little bit of something that might clear the way depending on what's going on. I think for most people that's not necessary. And it's usually the first strategy. It's usually like, we need to obliterate this Pseudomonas or else you're not going to get better. And right, exactly. So it's a little bit wild. And I think if you can frame it more as an opportunistic bug, and as you were saying, and you said it really nicely, trying to figure out what in the environment is creating the opportunity for this particular bug to thrive. And I will say one other thing that I think is important in the context of this conversation is the whole entirety of the microbiome. Like usually if you have some of these bugs overgrowing in large amounts, it's usually also a lot of the time you're going to see lower levels of some of the good microbes. It's not like it's almost a teeter.
Yeah, seesaw or teeter-totter.
Teeter-totter. Yeah, seesaw situation. So like that's something huge. And again, if you're throwing herbals and antibiotics and restrictive diets at this thing, again, you could further lower good guys, further creating an opportunity for these bugs to overgrow. And it is just so wild that it's such a common practice to go to that page and be like, oh man. And that's usually the page that people are getting red flags or out of the reference range. I know, again, like definitely seen, I know we've talked about GI maps that have shown positives for outright pathogens.
That don't seem to be accurate.
Right, that don't seem to be accurate.
Oh, I'll say it.
But the opportunistic side of the equation, that's usually where most people are like, oh my gosh, I have strep, I have Pseudomonas, I have this, I have that. And it's like, it just creates this, like, I just need to kill these things mentality. And usually even, again, even with some of the interpretation guides and things like that, sometimes they're like, you need to remove or whatever the 4 R's.
Yeah, the 4 R's.
Which again is protocol-y and not really appropriate for most people, in my opinion.
Yeah. And here's the thing, like one thing I want to kind of start us off early in the episode with also is that this goes for all testing on planet Earth and any diagnostic thing that you get done. You and your clinician are making the assumption that the abnormal test result is related to or causing your symptoms. But that is an assumption. That is not a proven fact until you make an attempt at treating the thing. So 2 different scenarios. Let's say you got a stool test back and it said you had candida. And you hypothesized, and your practitioner hypothesized that that candida is causing your bloating and your brain fog. So then you try to treat the candida. And let's say you do a treatment and then you do a retest and the candida is gone, but your symptoms still remain. That's a good data point that shows you either the first test was incorrect or the candida is not driving your symptoms forward. And I've seen this shake out. Like I still remember one of the last GI maps I ever ran, actually, if not the last one that I ever ran. This guy came back and he had, I think it was like 10 10,000 times higher the amount of Pseudomonas that he was supposed to have. You know how it's like, E to the third, E to the fourth, it was 10,000-fold higher than what he was supposed to have for that particular opportunist. And at the time I was becoming skeptical of this test and the validity and the utility of it. And I wasn't going to make a huge deal out of it. But I said, that's interesting. That is something that maybe we want to try to address at least. So we took a stab at it. I had him do some antimicrobials. And we later did a follow-up stool test, and the Pseudomonas was completely gone, not detected. But his symptoms were exactly the same. So clearly, again, either the first test was inaccurate, which I wouldn't be surprised by. The Pseudomonas wasn't really causing the symptoms.
Right.
And, it's like, it's frustrating to hear that because people spend, $400 on some of these tests, and then they do repeat tests, and they do these difficult protocols, and they take expensive supplements, all trying to get rid of these things. But again, you're doing a trial more than you are a treatment. You're trying to prove or disprove the hypothesis. And I've seen numerous times where it appears on paper that we treated the thing, but then the symptoms don't budge. Or similarly, like I've seen people where they have, they have symptoms of candida, and then they do a candida protocol, and then they feel better, but no test has ever shown candida. And it's like, I think that there's a big conversation for the validity and clinical utility of stool tests and SIBO tests, probably a lot of functional tests, honestly.
Yeah. Well, and again, I think, too, things like brain fog or energy issues, and even gut-related things, like zooming so far in on one thing, it's even interesting sometimes when we work with people and it's like they take something simple like HCl or an enzyme and like 90% of their symptoms go away. I mean, that could lead to maybe some opportunistic pathogens. But again, like majority of their symptoms might have been from things going on upstream that are then creating the imbalance downstream. But some people could zoom in on that and say, oh no, like that particular bug's causing your gut symptoms. And in reality, there could have been some breakdowns upstream that were actually leading to that. It was more of a side effect of and again, like we're saying before, you have to figure out what is creating the opportunity. So there's always like, right, there's always this like conversation, but it is interesting because like you said, I've definitely seen some people who have a degree of imbalance gut-wise and they do some treatments and feel better, whether that's like a temporary thing or a long-term thing. But again, I think it at least shows that in part, some of the symptoms are potentially being driven by microbiome stuff. If they do like antimicrobials and feel a little bit better, it's not necessarily at the heart most of the time. Like there's usually a lot of other factors you want to pay attention to. Like it could be driving the symptom, but it's not the root, or in part driving the symptom. It's not
the root of the root.
Right.
Like maybe the bacteria or the yeast is driving some of your symptoms forward. And that is a root for those symptoms, so to speak. But again, you need to get to the root of the root and ask, okay, if this critter seemed to be causing some of my symptoms, why did it get the opportunity to come out and give me heck? Right? Like what opened the door, and then examine those things. And again, the thing that typically will open the door is going to be something like dysbiosis, like low levels of good bacteria, so you don't have the inhibition coming from the good microbes anymore, or insufficient or inadequate digestive process like HCl. But again, it's interesting. So on the GI map, for example, in the interpretive guide, they will talk about, oh, this microbe is associated with low stomach acid. It's like, okay, so are your symptoms actually due to the presence of the microbe itself, or were your symptoms just due to low stomach acid and it had nothing to do with the microbe? Because remember, something like low stomach acid is going to cause other stuff. Like you're not going to be as good at digesting your protein. You're probably going to suck at least a little bit digesting and absorbing your B12, your iron, calcium, magnesium. It's not going to acidify the bolus of food going into the duodenum. So you're not going to get the bile squirt and the pancreatic enzyme squirt that you normally would. There's going to be some pH changes. Like there's a lot of things that something like HCl is going to affect. One of many is going to be the ecology of the microbiome in the upper part of the intestine. But like it could just be that the microbe is coincidental and your symptoms are more related to the actual low stomach acid versus the microbe that the low stomach acid allowed to grow.
Exactly. Yeah. And again, in that particular situation, maybe supplementing with HCl, both for one thing, treats some of the symptoms, but also affects the environment from more of a root causal standpoint. Now, you would still want to maybe assess why the stomach acidity is low. Like there could still be more questions. The root of the root of the root. But yeah, like that would be a much better option for that particular person than diving straight to the microbiome part, which is just another thing, I think, in general. But I think that the pathogen and the way it's worded and the way it's perceived now in the holistic space has you drilled straight down to the microbiome, and like you have your blinders on that microbe because it feels scary, it feels intense, it
feels important.
Right. It hits on the health anxiety button, like major.
Big time.
It's going to poke that little itch of, ooh, this is it. And like, you know, I have to get rid of this thing and then all my issues will go away. Like there's kind of this itch it scratches. And again, in reality, like we've been saying, like what created that environment is the core question to figure out. Now, again, whether you need to like do anything like even specifically for the microbe, like for someone that's more of an HCl issue, you might not even need to do much microbiome-based strategies. You might just need to figure out why your digestive juices are low. And then things can kind of regulate on their own without much effort.
Yeah.
But I think it's important to look upstream for issues, whether it be like maybe immune system things or digestive capacity things or motility things.
Vagal
tone. Like, again, all the things upstream are going to affect everything downstream. So again, jumping straight to the microbiome and like the remove and the 4 R's, like focusing on the microbiome can leave your wheels spinning in the microbiome piece without seeing the whole picture.
Well, there's this element also, you had mentioned that this kind of like taps on an itch that a lot of people have, which is the health anxiety, health kind of fear stuff. I think also we have to keep in mind that this is a group of people who have been through a lot. Right. They have probably been to numerous providers. They've done colonoscopies, endoscopies. You know, they've been scoped this way and that way, and they don't have a lot of answers. So then when they go to an alternative provider and they shell out the money to see somebody like that, it feels like they got the answer that they have been craving for so long. And it feels like, oh my God, this is the end of the journey. The end is in sight. This is what I've been dreaming of. It might have been a multiple year or heaven forbid, multiple decade battle with what was just labeled IBS. And it could feel like, oh my God, I see the finish line finally. This is going to be my answer. So it's understandable that people put all this weight into this. And likewise, for the practitioner side of things, I think that every practitioner, whether they're going to tell you outright or not, they want to be the hero. Like they want to help you. They want to do a good enough job at their job that you feel compelled to write them a nice Google review, right? Like that's just the way that business ownership is. Like you want the customer to be satisfied. So of course, when they find something that feels like a big aha smoking gun, of course, they're going to put all of their eggs in that basket and hope and pray to God that they're onto something. Yeah. And again, I think that generally it's with the best of intentions, but we talked about this in the functional medicine episode a while back. Unfortunately, part of this that's wrapped up too is that these fancy schmancy tests and the ability to order them and the ability to interpret them and the ability to use this information, this is a big selling point for the functional medicine space and the integrative space. And I think a lot of people in this business feel like that's how they're going to get you in the door, is by hyping up the importance of this type of testing and making you feel like, oh, there's no way I could possibly do this on my own. I absolutely have to go to Dr. Dedeza to get my GI map. Right. So like there's also, I think that there's good intentions, but I think there's also some marketing and some like business practices that are unfortunately very common in this industry and that doesn't get talked about enough.
Whether providers realize it or not, and I think I still am under the assumption that providers usually are good-hearted and are trying to help, just like you're saying, but
well-intentioned but ill-informed.
Right. I think what's interesting is the testing, the way it kind of preys a little bit upon the anxiety piece is it gives this illusion of certainty, which again is what every person with anxiety wants, is we want to figure out exactly what's going on. But like you're saying, that's not always the case with these tests, and it's not the whole story. And it's, again, it's not the promise that people think it is, which then usually ends up leading to more doubts and more anxiety over time because, oh man, I treated that bug and maybe I got a little bit better, but now I feel worse actually. Like, and then again, it just typically leads to more doubts from the standpoint of what I see typically with patients and clients is like, it gives this illusion, which really scratched the itch for a while that, oh, I'm getting some certainty. And I think, honestly, a lot of providers in this space have a degree of health anxiety too, from the functional side of things as well. Like, they love certainty. And so this testing is very appealing to them as well. So there's a little bit of maybe people drawn more into the functional space could have more of a tendency to over-rely on some of these tests. And then people who are seeking out these tests and seeking out functional providers are going to get this like hit of certainty that makes them feel good for a while until it doesn't. And again, I think eventually what I have seen is that the patients that I work with get a little disillusioned of testing because, you know, whether it's the 5th test they've run or the 20th test they've run, they're still not well. So that's just something you see over time too. Like, if these tests were really that definitive, you wouldn't see someone running a million tests and still kind of spinning their wheels. And again, if it was really that easy of like, oh, I could just treat the opportunistic pathogens, we wouldn't be seeing people coming to us having been through the rigmarole from 5 different providers who've all tried to remove, replace, or do the protocol, whatever it is. I can't even remember what the 4 or 5 R's are.
Yeah, I forget too. It's remove, replace, reseed, and
recycle. I don't know.
Reintroduce. I don't even know.
Right.
But you're right. And again, it's tricky because, like you said, oftentimes the patient very obviously wants certainty and they just want this shitty, pun intended, journey to end. I think also another piece is that on the provider side, yes, I agree. I think a lot of providers in this world have their own health anxiety, health OCD kind of stuff and like orthorexic behavior. And like they've been sipping the Kool-Aid for long enough and they don't even realize it. There's also this element of business ownership, right? Because if you go to a doctor at a hospital, they're not a business owner. Right. You go to a hospital or a clinic or something or urgent care, and that is an employee working for a company. And I'm not knocking that, by the way. But my point is, when you go to a functional medicine provider or an independent RD or health coach or herbalist or whatever, that person is also a business owner. And something that doesn't get a lot of cred is like, especially when you first start out or when you're first kind of changing specialties, you know, going from conventional medicine into functional medicine or going from chiropractic into functional medicine, it is terrifying, whether anybody wants to admit that or not. Right? Like, do you remember how much you were shitting bricks when you saw your first patient or your first client?
Yeah, I mean, it makes me laugh because my little sister is a dentist or like about to, well, I have an older sister that's a dentist and then my younger sister's becoming a dentist. She's graduating and she's like, I don't know what I'm doing. Like, and I'm like, well, you're going to be a dentist. Yeah. So it is funny. I feel like there's a level of imposter syndrome, no matter who you are, typically at the beginning where like, oh, I don't know what to do. I want any guidance I can get my hands on. And it's like,
bingo. And that's what happens is you seek guidance and you seek clarity and confidence and certainty Ooh, are those 3 C's that I just rattled off
Whoa.
there? Whoa, new thing. But seriously, you're seeking that out. And then conveniently, these companies swoop in with, here's our fancy schmancy test that literally has like big red bold lettering if something is out of range. And we've done all the work for you because, oh, here's an interpretive guide. You just have to reference this PDF and you're good to go. And here's like another company that's affiliated with us that makes the supplements that will miraculously cure whatever you find on our test. So I get how practitioners get swept up into this. There's the element of like, they want to be the hero, they want to help you, they want the customer to be satisfied, and they have the best of intentions in that way. But also like, these people oftentimes are really grasping for protocols, and this is, a pretty easy way to build a protocol is just memorize, if I see Staphylococcus on a GI map, I prescribe oregano. And if I see this, I'm going to prescribe this. And like, you do that enough times and you get the protocol in your brain. But it is infinitely harder to have real conversations with people and tell somebody, you're eating 700 calories a day.
Right.
You can't do that.
Yeah.
No, you're being a silly goose.
The coaching aspect is something that you get much better at seeing over time. Coaching is hard work. Humans
silly gooses.
Humans are silly gooses, and we're complicated and we're beautiful in so many ways. And like getting the right coaching, I think, is what typically leads to the best results. But the coaching shouldn't necessarily be this like very certain process. It should be a learning process. It should be trying to help you get over barriers. But like that's where most of the progress lies, is in having a good coach that can help you navigate like, okay, this happened. What does this mean? Like, do we try this thing next? What foundational pieces are still going on in the background that we need to work on? Like, I think that the coaching piece is huge. And I think just to clarify too on the certainty piece, most of the time, there's this clear, distinct shift. A lot of times, if I can see a client start to be like a little more open to the idea of uncertainty, they're going to make more progress, which I know sounds backwards to what is typically promoted in the holistic space, which is like test, don't guess, this very intense process of like, you have to figure out what microbe, what hormone, what like everything that's going on. And so
I hate that expression
you have
so much,
that,
by the way.
Like very certainty based approach. But I will say, like, when the switch flips, when I work with people where they're like, hey, like, I'm just going to trust the process. I'm going to try this thing. It might go great. Maybe it doesn't. But if it doesn't, we'll learn something from it. I think the more open you can be to experimentation, like you're saying, trial and error, the more progress you're going to have and the more balanced the process is going to be versus the extremes of like, we have to go after this boogeyman. That Klebsiella is causing every symptom you've ever had. The second we get rid of it, right, guaranteed. The second we get rid of it, blast that thing with some oregano for 5 months, we're going to be good to go. It just doesn't usually work out that way, or else people wouldn't find us. Because that's typically what we get the remnants after the clearance of these opportunistic microbes, really. Like, rarely am I seeing someone with like Giardia. I've had Giardia patients, but like rarely am I seeing someone with outright pathogens. Usually it's, oh man, I had these 3 bugs flagged on my GI map, and then like I have dysbiosis now and we've been treating it for 2 years. But, like, we just get the remnants of that, the downstream of that process. And so if it was really working, the aggressive approaches, people wouldn't be finding us.
Yeah. Well, if it was just as simple as obliterating the bad guy,
right,
we probably wouldn't be here. But, and again, like, I think maybe occasionally that does work. If I'm being really honest, it probably wouldn't work for the listeners of our podcast. But if you think about it, if you had a normal American, average American Joe Schmo, and let's say he had some degree of pooping problems and happened to go to a naturopath or something. And let's say that this person had a dietitian or on staff or was really like chemically balance themselves. Like, let's say they go to the right clinic and they do a good intake process and they have a discussion about, okay, here's how to clean up your diet. Let's focus on protein and fiber, and let's get you exercising a bit and get to bed by 11 o'clock. And also, by the way, there's some Klebsiella. Let's just mop that up real quick and do like a dose of berberine for a month or two. I do think that inhibiting the bad guys can serve a purpose for some people when it's a small piece of a holistic health promoting plan. But if the whole plan is just kill and starve the microbe, and if you're putting all of your eggs in this one basket, it's almost guaranteed to fail you.
Right. Exactly right. And I think, again, I know we've discussed this before. By the time you get to the point where maybe you want to use some antimicrobials with someone, typically they've already worked on the foundational pieces so that it actually helps, versus, again, just throwing it into this environment that's already leading to the imbalance.
Panic, desperate, I need something right now kind of energy.
Right. But I think focusing on, again, upstream foundational pieces, if you even have to go a little bit more, like sprinkle some herbals in the mix, whatever it is, if you have to do a little bit of clearance, it's going to be way more successful in like a one-time deal versus the scenario where you're like round after round and it's like this boogeyman that never goes away. And so that's something to keep in mind too. Like, even if you have to go in the aggressive approach, usually if other pieces are together, like you said, focusing on putting eggs in multiple baskets, it's not super hard to clear something like that out.
Yeah, I mean, it kind of feels like the conversation with leaky gut in a weird way. So I had shared, with my story, I chased my tail and I chased leaky gut for a solid 2, if not 3 years. And I probably, no joke, spent multiple thousands of dollars on Repairvite and L-glutamine supplements. In reality, you turn over a new crop of epithelial cells in your gut lining every 3 or 4 days. So in theory, if you are doing the lifestyle stuff and the digestive stuff and the nutrition stuff, and like if you're crossing all your T's and dotting your I's with the unsexy basics that we mention every episode, by the time you get to leaky gut healing, you really should only need to patch that up for like a week or two, and then you should be good to go. But if you are perpetually chasing this one thing and hammering the snot out of it, that's an indication that you're missing something else. And similarly, if you feel the need to continually pound Candida or Klebsiella or E. coli or whatever, that's an indication that there's more going on than just the Klebsiella and you need to look elsewhere. And frankly, like, I'm going to put in a plug for myself, if I may. If I may.
Nope.
This is exactly what I do in FODMAP Freedom. I tell my students every single week on the Q&As, and I'll say it here too. Week 0 through 11, I'm teaching you how to build a SIBO-proof body. In week 12, that's me saying, okay, if you feel the need to kill the thing still, here's how you target it effectively. So that's where we're going to talk about antimicrobials and biofilm disruptors and targeted diets and ways that you can inhibit or otherwise kill the pathogen, or the opportunist in this case. But laying that foundation first and making sure that you have all of the other unsexy basics dialed in, and you're working on nutrition, you're working on sleep, you're being mindful of stress, you are chewing your damn food, you're doing all of those things, doing that first and then going in with antimicrobials, A, they're going to be so much more effective, but B, well, you might not need them at all, for one, but if you do use them, it's going to be a much lower dose, right? Would you rather keep pounding the snot out of antimicrobials for 6 months? Or would you rather take like 3, maybe 4 weeks of a low dose of berberine? I'd rather do the second one, personally.
Yep, I 100% agree. I think too, we've talked a lot about this, and part of the environmental factor that opens the door to opportunistic microbes is, again, like some of the dietary measures that people take in this space too. Like if you're cutting out fiber, one of the best ways to inhibit a lot of the pathogens is to change the pH and eat fiber and make sure you're feeding the good microbes, which again can inhibit the opportunistic pathogens. So yeah, it is wild too that that's a part of the mix. And just working on the diet piece is going to be so huge. But other interventions, maybe like probiotics, prebiotics, could certainly help as well to shift the tide without having to go as aggressive as an herbal. Not saying that it's always aggressive per se, but like that to me is the next rung up. Like if you're thinking of like road to aggressiveness from a microbiome standpoint, I always think of like prebiotics, probiotics are kind of like pretty low risk. They could be really effective, so I don't want it to sound like they're weak by any means, but they're sort of an option that can definitely shift the environment a bit and lead to less imbalance.
You're not going to do permanent damage,
right,
with a probiotic or a prebiotic. That's the way to maybe frame this,
right?
Versus a prescription antibiotic.
Prescription antibiotics, like maybe most aggressive, and there could be a spectrum with the different types of antibiotics. Because again, I always hear like rifaximin's fine, which again I don't really agree with, but
it's better.
It's better.
Sure.
It's for certainly better.
Not without consequence.
Right. Exactly. I think that's how it's presented. It's like it just stays in the small intestines, but it's still affecting the small intestine microbiome, which could lead to symptoms and imbalance too. But yeah, I think from my standpoint, it's like the progression of like herbals can certainly, if they're misused and abused, lead to some problems too, and can lead to imbalance too. So like you still want to be careful with them, more careful and more considerate than maybe probiotics, prebiotics. And then antibiotics, again, I think are like the next rung up where and I think I'm so happy they exist. So I don't want to sound like I'm against antibiotics. They have a time and place, but I typically would not say opportunistic pathogens would be a time and place to take an antibiotic.
No. Well, and if I can interrupt you for a second here, I wanted to share this earlier, but I forgot, so I'm going to point it out now. One really weird kind of mindfucky thing to think about with regard to these stool tests and these pathogens is there is no research that tells us what the ideal or normal amount of this bacteria actually is.
Right.
None. Like, I challenge you, I dare you, I will give you $5 if you go on PubMed right now and produce a decent study in humans indicating where we actually want Klebsiella to be.
Right.
We don't freaking know. We have some ideas, and we do have some aspirate studies coming out from the Reimagine work that Pimentel's group is doing. So we're getting a little bit more of a sense in the small bowel, but you can't tell me, like I'm looking at a GI map right now. They're saying that Klebsiella species in their totality should be below 5.0 times 10 to the third. Who decided that?
Right.
I will tell you, it wasn't a researcher.
The 100 people that they just made their population, their stool test like baseline reference range off of is not enough.
Well, that's the thing.
Right.
So what people don't understand, and this is not advertised by the stool testing companies, is that they are basing these reference ranges off of a very small cohort of people that they deem to be normal. And I can almost guarantee you, I bet you $5, they're just having all of their employees do the test and like their employees' families. And
right.
Like, here, have a free stool test. Help us establish our reference range. Thanks. And I say that with some confidence because I've spoken with another very popular company, and I don't know, should I say?
You can say. I mean,
Genova. Okay.
Like
I spoke with Genova years ago because here, you have to get the story now. Poor Amy's heard this before. So I had a patient come in to see me, and she was one of these people who had prescription antibiotics to treat dysbiosis with absolutely no freaking reason to do so. And she had like 3 rounds of prescription antibiotics. And the IFM trained MD was like, gosh, your dysbiosis is getting worse. You know shit, Sherlock. Of course it is. So anyhow, we were going over all of her intake and her stool testing when she first started with me. And I was asking, like, why did you have antibiotics? I'm not seeing anything on here that warrants antibiotics. And she pointed out the bacteria, and it was Pseudoflavinifractor. And I'm pretty savvy with the microbiome. I dubbed myself the gut microbiome queen on Instagram and YouTube for a reason. So this was maybe I don't know, 5-6 years ago. And at that time, I had never heard of Pseudoflavitifractor. And I thought, that's weird. I feel like I should probably know the name of this. Like, I'm a nerd. I read research. So I took to PubMed and I searched for Pseudoflavitifractor. And I kid you not, Amy, again, this was 5-6 years ago. I found like 8 studies, maybe, that mentioned Pseudoflavitifractor. It wasn't the whole focus of the article. It was just like, oh, BTW, here it is kind of a thing. One study actually was in humans. All the rest was in broiler chickens.
Oh my gosh.
Yeah. Broiler chickens. So I called Genova and I asked them point blank. I said, what is the deal with including this bacteria on your GI effect stool test? I don't understand why this is even mentioned. Like, there's really no human research indicating that this microbe is important. And their actual answer to me was, well, we thought it was important, so we put it on there. What do you mean? You thought it was important, so you put it on there? That makes no sense. That's not how this works. You can't just
Nikki, you don't know how it works. They can't dub something just important and just roll with it?
No. And people are spending, $400 on this GI effects. And this particular poor woman had 3 rounds of prescription antibiotics, all to treat something that, worst case, doesn't need to be treated. Best case, we just don't have any information on.
Right.
Like, how does this make any freaking sense? And I know I've spoken with Genova, and I don't think it's a bad company, for the record. I still use some of their stuff, but I once asked them how they determine their reference ranges, and they said that they had, I forget if it was like 30 or 50 or 100 people, I forget, but they basically just had a cohort of people that they thought were healthy, and they had them do the test, and then they took the bell curve, and bada bing, bada boom, there's your reference range.
Right.
Who's to say these people are actually healthy?
Yeah.
They're just average Joe, Jane, America people working for Genova, probably. Like,
right.
Is that what we're striving for? I don't know. I really don't know the answer.
And again, it does make me wonder too, like, well, if it depends, again, like, are you using people that might have had, because with conventional testing even, I'm thinking of blood work, like, people they're getting the reference ranges off of people running the thyroid panels and thyroid labs. So you're having a higher propensity of people that could have thyroid issues determining maybe the reference range there. So, even for conventional labs, they can run into this issue of like, who's the population of people that you're basing your reference points off of? Are they people that are going to be more prone to the condition? So again, it is really interesting that some of these labs too are just pulling Lord knows who. Like you said, maybe it is just like the workers from the GI map or the workers from Genova, like creating this reference range. But yeah, who's to say what does healthy mean? Like, describe what that looks like. Did you pick people based on blood work and based on certain parameters, or was it literally just like, you seem healthy?
I feel like it must have been that, because this is a whole can of worms to get into, but I was sharing off screen earlier today on Marco Polo.
Mm-hmm.
I don't even know how important microbiome precision is anymore, because I'm a good example of this. I feel fine. I don't really have any big issues, a bit more of a predilection towards constipation in recent years, but it's not anything to really shake a stick at. I have 0 bloating, 0 abdominal pain, 0 cramping, 0 food issues other than gluten because I'm a celiac.
Right.
But if you look on paper, my bifidobacteria look kind of and my lactobacillus isn't perfect. And like, ever since I had antibiotics last year for the ear surgery, my Akkermansia hasn't been perfect either. But I feel fine.
Right.
So I don't know. I don't know if it's right to put this idea in people's heads that the way that they're going to feel better is if their microbiome looks perfect on paper. We're in this very cool but very weird place. And again, this doesn't get talked about. Our understanding of the microbiome is in its infancy.
Right.
And to kind of borrow something from Michael Pollan once said that the field of nutrition is approximately where the field of surgery was in the 1600s.
Right.
Meaning fun to watch, interesting, but maybe you don't want to be on the table quite yet. And I feel like if that's where the field of nutrition science is,
oh God,
like
yeah.
the world of microbiome knowledge and microbiome testing and microbiome like medicine is wherever the field of surgery was in the year like 200 BC. Right? It's so early on. We're still drilling into people's skulls and doing bloodletting and shit. This is not, it feels very cutting edge.
Right.
I was going to say on the cusp, and that didn't sound right. But it feels cutting edge and it feels very precise. And we have these tests that are giving us very precise reference ranges for very specific named microbes. And we know what's good and we know what's bad. And we're going to treat this. But like, can we really?
Well, I think like a good example of that is just if you do like full genome sequencing, how many microbes they can't label. Like there's just like 50% or something crazy of your microbiome we just have no information on. So like you're making judgment calls on the other 50%. And I think we know some cool things, and I think you can take into account those cool things, but also knowing that this isn't like a set science and there is trial and error like you mentioned before, and we can't really have certainty when we don't even know what the other half of your microbiome even is. There could be some other major probiotic microbe that hasn't been discovered yet that's super imperative that, you know, you might have a lot of even if you don't have a ton of bifido. Again, there's so many different scenarios and things we don't understand. Like you're saying, it's much better off to err on the side of like, we know some things and it's good to dabble maybe a little bit and to try some things that are reasonable, but don't put all your eggs in that basket because, again, we don't even know what 50% of that basket is.
Well, yeah, and this is what we've been saying for a long time is like, you could use these tools. You could use low FODMAP. You can use restricted diets. You could use the stool test, maybe not one in particular. Some of us know I have opinions about one. But, you know, like you could use some of these tools, but just don't put all of the weight of the world and all of your hopes and dreams into this tool. Like, to be frank, I have seen scenarios more so using like 16S type testing. So something like Ombre, which used to be called Thrive, or if you're overseas, there's one called BiomeSite. But using that kind of cheapo test, I've seen patterns where like, I still remember I had this woman who had like the mother load of methanogen on a 16S stool test. Normal is for it to be below like 0.1%. And she was at like 7.7% of her total microbiome, which was nuts. And
methane
we did
galore.
Yeah. Yeah. And she was severely constipated. Obviously you would. And we did, you know, the methane kind of things. We did like PHGG and BioGaia and maybe a Trontil, I forget now. We did maybe 2 or 3 things and we got her to a point with everything else we were doing, we got her to a point where she was pooping every single day. And she actually said, well, I have to like allocate time every single day to pooping. This is kind of weird. Like this is like a scheduling thing now. I have to actually make the time to poop, which was weird for her. And we observed when we did a repeat test later on that her methanogen load came way down. I forget what it came down to, but it was like 0.5% of her microbiome compared to 7.7%. So, you know, it's like, again, we got the test back and we saw the high level of a methane producing organism and we deduced that that could be related. And then we went in with a trial and experimented and she came back and said, I feel much better. And then the repeat test basically like backed up what she had already told me. But that's a much different vibe than what typically happens in the IBS and the SIBO space. It's like the sun rises and sets on the GI map and there's nothing else that matters. Your experience, your symptoms, your whatever else, be damned. We just have to follow what's written on this piece of paper. And it doesn't make any sense. We're not there yet.
Right. Yes.
Now, so all of the first portion of this episode was basically us saying, you probably don't need to laser in on specific named things. However, let's just take a couple of minutes, if we can, to talk about a few. And here's how I want to break it down. You ready? Ready for this? Let's just clump all of the Proteobacteria together.
Yeah, I was thinking the same thing.
Because that's how it works anyway, right? Like you don't necessarily need to get into the weeds of like targeting Klebsiella versus Pseudomonas versus Citrobacter versus whatever else. Guys, they all roughly behave the same way and they are susceptible to the same kind of stuff. So it seems.
Right.
So what might be some of your go-tos if you wanted to target something in the Proteobacteria phylum?
Yeah, I think again, like ADP might be a good one to dabble
Which is an
with.
emulsified oregano product.
I think that works fairly well. You don't have to take insane doses of it either. That might
You mean not the Alison Seebecker dose of, was it 5 tablets 3 times a day?
No, I think you're going to be okay.
I'm not exaggerating, by the way. That's really what she does.
So that could be something sort of interesting to try. I've still at times done kind of more broad spectrum-y stuff. Like I still like FC-cytyl dysbiocide just for general like pruning, so to speak. But yeah, I do like ADP a decent amount for...
I think lactoferrin is another one that's nice.
Oh, yeah.
It's a biofilm disruptor, but it also has some like immune modulating and anti-inflammatory kind of components to what it does. So that's kind of nice. Bismuth also is really nice. I had a guy recently, and we're working more on like hydrogen sulfide kind of stuff, and he has Crohn's, so it's a little bit of a different ball of wax. So here's the thing though, getting back to the root of the root of the root, right? Like, why would he have had hydrogen sulfide? Why would he have SIBO? Why would he have some of this stuff? He is a business owner and he hasn't taken vacation in over 5 years. And no joke, every time we meet, I give him crap about that. And I'm like, all right, when are you taking a vacation? When are you doing a staycation? When are you going to take any time for yourself, bro? And again, it's like dysbiosis is not hard to treat. SIBO is not hard to treat. Getting through people's thick skulls is the difficult thing. Yeah, I would tell him the same thing to his face. So I feel comfortable saying this on the podcast. But seriously, like getting people to take vacation when they haven't taken vacation, or getting people to go to bed earlier when they love staying up late. Those are the things that are actually hard to do. Right. Giving you a prescription based on your GI effects, that's not that difficult. But what I was going to say is that he had some great success recently taking Pepto-Bismol. But we didn't want him to take Pepto-Bismol for a long period of time because it's got like the funky, weird pink food dye stuff, whatever they do to make it that color. And it has acetaminophen in it. And you can't just take that for months on end. So I had him switch over to a different bismuth product. There's one that I've used for years. It's a combo product, but it has bismuth in it. It's called Biofilm Phase 2 Advanced. And we swapped him over to that, and he's doing great, kind of like lightly inhibiting and biofilm disrupting with some bismuth while we get other ducks in a row and buy him some time. I will say, though, what I wanted to perhaps lead with, so all of those biofilm disruptors and antimicrobials, I think still are useful. But what I would actually lead with is you can inhibit Proteobacteria by feeding and nurturing your good guys. And this is very well established at this point. In the grand scheme of microbiome research, this is pretty well established. And you could do that with something like inulin, or you could just eat FODMAPs, right? But like inulin...
Isn't that the crux of everything? Like,
yes,
the way out is to eat FODMAPs.
Probably.
But you're terrified of FODMAPs, so...
and that's where the juggling comes in, and that's frankly why we have jobs, right? Because it's how to implement the stuff. That's where people get stuck.
Like we were talking about before.
Coaching. Yeah, but you can inhibit Proteobacteria via something like inulin or high FODMAP foods, because those things promote the production of short-chain fatty acids, and then the short-chain fatty acids acidify or lower the pH in the terrain, and then Proteobacteria members don't like to grow in acidic terrains.
Right.
Similarly, you could get the same effect possibly by increasing lactic acid production with something like lactobacilli, or a prebiotic like green tea that feeds lactobacilli.
Right.
Even lactulose. I remember this, so I don't know we weren't together yet. We weren't podcasting yet at this point. So when we lost our dog, Bonnie, our last dog that passed away, Bonnie, she went into acute liver failure. She had very elevated liver enzymes for years, and the vets could never figure it out. And they basically told us she will be perfectly fine until she's not. And that's exactly how it happened. And she went into acute liver failure. We brought her over to NC State Vet School, plug, second in the nation. But we brought her over to the NC State Vet School doggy ER. They pretty quickly figured out what was going on. She had very high levels of ammonia in her blood. And what they did for the treatment, they gave her oral and enema lactulose. And I remember being really curious about that at the time. And I asked them, and they were explaining, well, what happens normally is your microbiome produces ammonia, and then your liver basically deals with the ammonia and processes it and gets rid of it so that the ammonia doesn't build up and impact your brain. But in her case, her liver was failing, so she wasn't able to process ammonia anymore, or not as efficiently. Right. So it was impacting her nervous system, and that's why she was getting all of these really weird neurological effects. So their rationale was, we can inhibit the bacteria that make ammonia by using lactulose as an enema and administering it orally. And it worked. They got her ammonia level to drop really significantly in a short amount of time. And when I was researching it, it made sense because lactulose feeds the good bacteria like bifido and lactobacilli. They make cool chemicals that inhibit the proteobacteria, and then it's the freaking proteobacteria that make ammonia. And so basically they were just using this as a way to inhibit proteobacteria. And it worked. It definitely worked. They remeasured her ammonia. She kind of came back to us a bit more neurologically. But it was a really cool learning experience as a microbiome geek to see that they were able to orchestrate this and kind of prove the hypothesis. So heck, even something like lactulose that feeds bifidobacteria and lactobacillus. The sky's the limit how you're going to inhibit the proteobacteria with prebiotics and food. It's just a matter of which one you want to pick.
Right. And I think the only caveat I would say to that, because I think that that's by far the best way to do it, the best first trial thing to do. I think if you have any like hypersensitivity to fibers and things like that, there could be a couple different things you could do preceding that might help your tolerance to some of these things like maybe butyrate, SBI, like things that kind of lower the immune activation in the gut might help the tolerance. Again, a lot of people don't need that. They can kind of move through like a little blip in bloating or like a little blip in symptoms when you add in something like an inulin or FODMAP type things. But some people, again, I think might need to like dial down the system a little bit, and then they tolerate those things much better.
Yeah, that's a valid point. We can't just tell all of our listeners to go hog wild with spoonfuls of inulin. But another point, and I think a lot of people already intuitively know this, is that this is where using the antimicrobials and the biofilm disruptors might be really handy, because they can help mitigate the symptoms enough that it kind of buys you that wiggle room, so to speak. And then once you get the antimicrobials kind of like keeping a lid on the symptoms, that's when you have the increased tolerance to bring on these different foods. But again, like in the SIBO space, everything is ass backwards, and you see people saying you have to kill the SIBO and simultaneously starve it. And so they're doubling down on the restrictive diet. It's like, no, that's the opposite of what you want to do. You should use the antimicrobial time as a window of opportunity to get foods back in lickety split so that you have the dietary inhibition coming in when you get rid of the antimicrobial.
Right. Such a good point.
Yeah. I'm full of them, Amy. I'm full of good points. Who are you kidding me? Before we go and wrap up this conversation about opportunists, remember, not opportunistic pathogens.
The name we shall not speak, or whatever it is.
That's right.
Harry
it's like
Potter.
Voldemort now, guys. This is our Voldemort. What would you like to tell the people? Can you remind them where to find you on the Instagram, perhaps?
Yeah, you can find me at Amy_Hollenkamp_RD. I'm making progress on my book. I haven't given a book update in a while.
Oh, yeah.
Kind of plugging along. I feel like the main thing now is like making sure things flow correctly. Like there's so much information when you write a book that now I'm kind of like, oh man, does this flow right? Do I need to like move stuff around? So I'm getting far enough along to where I'm like getting cognizant of that versus just like lots of research and word vomiting all over the page, sort of scenario where it's like, oh, I'm doing tons of work.
You're really selling it right now, by the way. Oh, she's just word vomiting.
I know. But yeah.
No, I know what you mean though.
Yeah, it's like you kind of don't want to like overthink it too much. And then you're kind of researching a ton and kind of putting together an argument, but then you have to make sure all the arguments kind of flow into one cohesive.
Maybe a way to describe it is you're moving from the territory of like kind of writing it as though it's 500 independent blog posts, and you're moving into, oh, this needs to be a cohesive thing.
Right.
Like you're moving from blog post writing into book writing almost.
And I think too, it's about, there's pieces now where I'm saying like, do I want to move that to the appendix? Like, do I want to have certain things like in the body of the book and have like little like appendices that might be more relevant to some people, but not for every single person reading the book. So there's a lot of decisions like that. And it's fun in a lot of ways, but some days you're like, you just like stare at things for a little bit too long where it's, you're like, well,
that's all right.
Maybe I need to take a break today because my brain's not computing what to do next.
Well, that's all right. I look forward to reading it one way or another, and not going to brag people, but I think I'm going to get a first copy. You suckers will have to wait.
Yes. You are. You're going to get a first copy for sure.
Here. All right, gang. I think that's a wrap. Also, I briefly mentioned this, but you can find me on Instagram at gut.microbiome.queen. And likewise, if you search Gut Microbiome Queen on YouTube, I have a YouTube channel by the same title. A lot of people didn't know that last time I surveyed this group. So FYI, I'm also a YouTuber. But yeah, we will see you back here for another action-packed episode of the IBS Freedom Podcast. Until then, take care of yourselves and go forth and tone thy vagus nerve.